Hi, everybody. Welcome. I'm Dr. Sydney Ortiz, and on behalf of Mount Sinai, I'm excited to introduce Just Talks, an equity and social justice lecture series brought to you by the Department of Psychiatry's Diversity, Equity, and Inclusion Steering Committee. Coordinated by the Community Engagement Subcommittee, this year's theme focuses on the relationship between psychiatry, mental health, and social determinants of health. And with that, I'm excited to introduce Dr. Mirna Mohanraj and her talk, Health and Inequity, a historical and environmental context workshop for the psychiatry community. Dr. Mirna Mohanraj is an associate professor of medicine and medical education, the associate program director for the Mount Sinai Morningside West Pulmonary and Critical Care Medicine Fellowship, and the Department of Medicine vice chair for strategic community engagement. Dr. Mohanraj's academic interests focus on curriculum development, physician trainee well-being, program remediation, equity and inclusion, and bioethics improvement and education. Dr. Mohanraj is recognized nationally for teaching excellence, leadership, and innovative curricula design. She is nationally recognized for scholarship in trainee well-being, the use of narrative medicine practices to humanize the ICU, and her hybrid program to develop the next generation of clinician educators. Recent honors include the 2024 APCC MPD Award for Novel Fellowship Education Implementation, the prestigious Dr. Nathan Case Innovations in Medical Education Award, and the Physicians Foundation 2024 Medical Innovator Award. Dr. Mohanraj leads initiatives to ensure equitable fellowship recruitment and to develop local partnerships that bridge the gap between hospital and community. Additionally, Dr. Mohanraj serves as co-chair of the Mount Sinai Health System GME Medicine Subcommittee and chair of the Mount Sinai Morningside West Hospital's Bioethics Committee. Thank you for joining us. We're so excited to have you, Dr. Mohanraj. Dr. D'Amberville will now share how to collect your continuing education credit.
Sorry. Hi, everyone. I'm Dr. David Damerville. Thank you again for joining today's Just Talks conversation. So continuing education credits for today's talks are available to psychologists who registered for CE and for free for Mount Sinai affiliated physicians, nurses, psychologists, and social workers only. We'll be placing information on how to collect your CEs and CMEs in the chat throughout the duration of the lecture. If you did not register via Eventbrite with your Mount Sinai email and would like to make sure that you obtain credit for your attendance today, please use the chat to DM your full name, credentials, and Mount Sinai email to myself or Timothy Stahl. Lastly, if you're joining as a unit or a group, please note each attendee's name and credentials in the chat so we can capture your attendance. If you have any questions or concerns about CEs or CMEs, just place them in the chat and myself and Dr. Stahl will respond. So thank you so much. Please enjoy the upcoming talk. We encourage comments, reflections, and questions to Dr. Mohanraj. And we'll get started in the Q&A box. All questions will be answered at the end of the talk. So you can start, Dr. Mohanraj.
Wonderful. Thank you so much, Dr. Ortiz, Dr. D'Amberville, for that really gracious introduction. And also thank you, and as well to Dr. Paul Rosenfield for the invitation to speak here. I know Dr. Rosenfield isn't, he might be on the phone, but I also want to acknowledge that he was very helpful in helping me to contextualize this workshop to the audience today, because I'm not a psychiatrist, I'm not an expert in mental health, as all of you are, and it was very helpful of him to give me some of those resources. I have no disclosures to report, sadly but true. And I just wanted to sort of give you a heads up that in about 10 to 12 minutes, we're going to be doing a group activity online. We will drop that link to a tool we'll be using, and I'll describe it and orient you to the tool. But just wanted to give you that heads up to give you a chance to activate your technology and sort of be prepared and not have to scramble right at the moment. So today, our time together, what we'll be focusing on is just some ground rules. Actually, we're going to skip the connection exercise. Sorry, that's for my live workshop that I do. I'm briefly going to talk about the history and impacts of redlining on communities and community health. We'll talk a little bit about our New York City neighborhoods and specific inequities with relation to health, and particularly with relation to social determinants of health. And we'll do at least one, hopefully two exercises using this tool to better understand how redlining historically has led to inequities in health, specifically with relation to heat and health and housing and health. And we'll put a psychiatry lens on both of these to better understand sort of the impacts of mental health illness. And then I hope to leave some time at the end for questions and answers, but please do, drop your chats, questions, any concerns or other insights into the chat as we go along. I always do like to start with the land acknowledgement, and we do acknowledge that this land is the homeland of the Lenape, who were violently displaced by European settler colonialism over the course of 400 years. They are a diasporic people that remain closely connected with this land and are its rightful stewards. We also recognize that New York City has one of the largest urban Native American and Indigenous populations in the United States. And I think they and their descendants are very directly impacted by what we'll discuss today. So if you're like me, you like to wander New York City, and when I walk around different neighborhoods, I live in Southwest Harlem, but as I wander different neighborhoods, really see sort of the major differences and the factors that shape neighborhoods differently. And I think some common things come to mind, both tangible and intangible factors. Things like, gosh, there's more trash in my neighborhood than other places, or wow, there's a lot more green space in this neighborhood than in my neighborhood. But when we think about sort of some of those intangible factors, I think they're not the ones that typically come to mind. Things like toxins in the air, things like differential policies from one neighborhood to the next, how land use is, where people have green spaces and where they have green organizations. What are the values of the community? What's the spirituality, the culture, the religion? What biases affect them? And what we're going to do today is focus on some of, not all of these factors, but some of the environmental factors that impact our patients, particularly in historically marginalized neighborhoods, and how these factors can impact their mental health. I think we all know public health is about so much more than changing people's behaviors at an individual level. It's about building a society that supports health and well-being. But for us to start thinking about how to build a better future, we have to start by confronting our past. And we're going to talk about a little bit this brief history of redlining. This is by no means exhaustive, but I just want to set the stage a little bit for what we will discuss for the rest of the talk. And if many of you are familiar with this already, I apologize for the repetition of information. Back in the 1930s, in the era of the Great Depression, as we know, unemployment rates were really high, and many people really couldn't make their mortgage payments. We had a similar sort of knowledge of this for those of us who were here in 2008. But historically, this Great Depression period was really key to the systemic inequities that we now see in our systems today. When people couldn't make their mortgage payments, there was a wave of foreclosures, and the federal government established the HOLC. This is the Homeowners Loan Corporation. And the goal of the HOLC was to refinance mortgages for homeowners with better terms, like lower their interest rates and give them some longer repayment periods, and to help people to make their payments so they could actually avoid foreclosure. Now, to determine what loans the HOLC would guarantee, they sent surveyors into every neighborhood all across the United States, and they asked them to appraise these neighborhoods. They documented the types of housing that was there, along with information about the people that lived there. But they also cataloged what they called detrimental influences, and these were often laden with racist descriptions of inhabitants of different neighborhoods. This is an example of one of these HOLC housing catalog documents, and you can see it details a lot of, probably very objective or could be objective things like the type, the construction, how old the building is, what state of repair, what's the occupancy, is it owned or rented, when was it constructed? But down here, you'll see some very concerning terms when they describe detrimental influences, obsolescence and poor maintenance, infiltration of Negroes, elevated structures on different avenues, and mixed races. But based on this information, both objective and non-objective, what the HOLC did was they made what they called residential security maps. And they did this for almost 250 cities across the United States, including New York City. Loan officers and appraisers and real estate professionals would then use these maps to evaluate mortgage lending risk for individuals and families. And on these maps, the HLC gave each neighborhood a classification. And you can see those here in this little box. So green and blue are best and still desirable, but then C and D, or yellow and red, are definitely declining and hazardous. You may recognize your neighborhood here on the map if you live in New York City. I live right here in Southwest Harlem, and I'm in a hazardous red-lined neighborhood. What this impacted was using this classification to determine whether or not the government would actually guarantee loans for people. And if you were in these yellow and particularly red regions, people were deemed ineligible for mortgages. They wouldn't receive a loan to buy homes in any of these areas. Not surprisingly, redlining really drove racial segregation. We all know owning a home is a very powerful way to achieve financial stability, but without investment in neighborhoods, without investment in housing that's equitable across neighborhoods, individuals and their families' abilities to find housing, find economic opportunities, these are very unlikely to improve. And these policies actually concentrated people of color in neighborhoods that were deprived of investment systematically, and it prevented them from accessing loans, buying property, while those in other neighborhoods, predominantly white neighborhoods, were provided more resources, opportunities to move up. As a result of redlining, people of color were denied access to these desirable neighborhoods. It was very hard to move from one to the next if you didn't own a home in the first. And there was a slew of other racist real estate practices, sort of illegally discriminating against who could live in what neighborhood, secretly or slyly asking people to sell their property because they were in a terrible neighborhood, buy it at a low price and sell it at a higher price to somebody else of the same demographic, and a variety of different areas. And these were exclusively done in the declining and hazardous labeled neighborhoods. Now, reinvestment has played a huge role in the last decades. Large parts of Manhattan were redlined, and you saw that on the map. And you can see that here if we're looking at some of these neighborhoods that are probably familiar to many of you. Many of these were nearly, 75% and upwards were hazardous neighborhoods, and many of the others were declining on this list. But reinvestment in recent decades has led to rising property values. It's led to the displacement of some of the former residents who lived here. And due to this gentrification, and we define this as a change in neighborhood character due to a rapid influx of wealth or investment, neighborhoods that were once redlined now have some of the city's most expensive real estate. And there's many on here. We look at neighborhoods like the Upper West Side and Midtown. We look at Soho, the Upper East Side, Clinton and Chelsea, and the Financial District. So this has been dramatically changed, but selectively dramatically changed for certain neighborhoods. So neighborhoods that were redlined in the 1930s, not only were they struggling then, they continue to struggle now. We know that 3 out of 4 neighborhoods remain low to moderate income if they were previously or historically redlined. We know that 2 out of 3 neighborhoods predominantly populated by people of color are in these yellow and red neighborhoods. And we see that greater income inequality in cities where HOLC high-risk areas are currently minority populations. Hypersegregation, Black and Hispanic residents, they tend to have less interaction with non-Hispanic white neighbors, and gentrification associated with some lessening of the segregation, but also with a marked increase in income inequality. And we can see that from the types of neighborhoods that have benefited from gentrification in the past decades. Now, redlining was officially banned in 1968, but it's a policy that is really quite notorious because it truly ended up worsening poverty and segregations all across cities in the United States in a very systemic and now institutionalized way. And it's now left this legacy of both income and racial disparities. As a result of redlining, even though it's no longer an active practice, generations of deprivation and disinvestment have sort of trickled down from that policy. And these populations and these groups have experienced the withholding of resources, opportunity, wealth, and health. And we'll focus on the health for the rest of this talk. We see a higher rates of preventable health conditions in these high poverty neighborhoods, which are home to a higher proportion of people of color. And effectively what this did was curate neighborhoods that actively contribute to illness. I know you're all familiar with this slide, the core social determinants of health. And what we'll use the rest of our time for is to talk about how systematically withholding these resources creates environments that make people sick. And what we're going to do is use this tool, and this is a really great time to kind of open that up. And I just want to orient you to this tool. So this is the New York City Access to Resources Data Explorer. This more recently, just this past couple of months, New York City has carved this out of their broader data explorer. So this one is specific for the environmental justice factors. And what it is, it's 100 data sets of factors relevant to environmental justice concerns and priorities in New York City. And it's broken down by 5 themes. And I'm going to just get out of my PowerPoint for a second and go to the Explorer and just kind of show you how I like to use it so that you can use it for our activity. So when you get out, open it, you can just skip this and go right to the portal, continue to portal. And you'll see here, if you click on access to resources, if you click on full data explorer, this is all of the data points. Let's give this a second to load. Sorry, everyone. Hopefully yours are loading a little faster than mine. Okay, so the full data explorer will give you every single one of these 100 data sets. It can be a little bit overwhelming. So if you prefer, you can scroll down and you can pick one of these broader themes or categories: access to resources, polluted air, hazardous materials, safe and healthy housing, polluted water, and climate change. Just for the sake of this demo, I'm going to pick hazardous materials because it's not relevant to the exercise that we're doing, so you won't be using this one. And really the first thing that I do is actually go to this tab, and you can do this right now, contextual overlays. It's already clicked for you. And click historically redlined areas. Oh, sorry for those pink dots. That should not be there. Let's see where that is. Okay. And as you can see, what you can do is go through all of these sub-themes. For this particular large category of hazardous materials, we have climate change sub-themes, we have hazardous materials in these neighborhood, we have various other contextual overlays, which I think are not as relevant to today's exercises. We have demographics by race, poverty rate. We have health indicators such as infant mortality, preterm birth, and premature mortality. And we have environmental justice areas. Once you have the redlining, historically redlined areas clicked, then you can kind of just play around with this. And you can zoom in to neighborhoods of interest. Tomorrow, I'm going to talk with some of the GI fellows on the same workshop, and they see patients from both the Upper East Side and East Harlem. So we're going to zone in on those for them. And as you get in a little bit closer and you click different factors that can affect environmental health, you'll see how these pop up differentially in different neighborhoods. So here's an example of how chemically intensive small businesses, the larger the bubble, the bigger the impact. You can unclick that and look for hazardous waste material storage and see how that plays out in the concentration in some of these neighborhoods compared to others. You can look at Superfund sites. There's really a whole variety for you to play with. I think the colors get a little overwhelming if you do more than 1 or 2 at a time. So that's my advice, is just to kind of click 1 or 2 at a time and then unclick and choose some other factors. Okay. So I'm just going to go back to our slides. And again, this is really just like kind of a rough experience just to play around with it, get a little bit familiar, and hopefully use it in the future for your own self-education and the education of others. And so what we're going to do is we're going to break my talking at you for the next 8 minutes or so, and see if you want to use this data explorer to answer this question. What factors may contribute to urban heat islands and heat-related mental health issues in New York City? So you might consider using that climate change tab. You might be thinking about air quality. You might be looking at the heat vulnerability index that they have in there. Just take the time, maybe about 8 minutes, like I said, explore this tool. And I hope some brave souls, when we come back, will be willing to either raise their hand and verbally share their experiences. We can unmute you from the webinar, or feel free to drop some observations in the chat. So it's 11:21. We'll come back at around 11:29. And if you have questions along the way, please feel free to pop them in the chat. Okay, everybody, maybe we can come back to the group and feel free to continue playing along as you share. I see at least one comment in the chat, but I wonder if there's any brave participants that want to be unmuted. You can just raise your virtual hand, and let me see if I can see you. And if you would like to share some of your observations, let us know what neighborhoods you compared. And if you don't feel like verbally responding to anything, feel free to drop your comments in the chat. While we're waiting for some of those brave hands, I see that there was one comment, not sure which neighborhoods would compared, but noting that there's significant lack of green spaces, I'm presuming in historically marginalized neighborhoods and redline neighborhoods due to a dense environment like concrete and asphalt, use of mass air conditioning, industrial operations, and also lots of traffic, although this is being worked on through congestion pricing. So thank you for sharing that. And absolutely agree, some of the key contributors to heat and heat-related illness. Just give it another minute to see if anybody else wants to raise their hand or drop any observations or insights into the chat. Okay. Dr. Damperville, thank you for sharing, noting that child asthma ED visits, solar installations, and air conditioning installations in Coney Island, disparate for some of the better invested neighborhoods for sure. And we'll see this in many of these other previously or historically redlined areas as well. Very similar patterns and parallels across these neighborhoods, despite completely different demographics of population and different environments. Harlem doesn't have a water supply like Coney Island does, and yet many of these same problems. Another participant said, I found the tree canopy cover function very interesting. I like that one as well. When looking at neighborhoods with less access to shade, whether in dedicated green spaces or on tree-lined streets or not. And I think that's really striking as too. And, as spring and summer comes and we're walking around the city, I think this makes me much more cognizant that even the parks, in some of these previously redlined neighborhoods aren't as parky as the ones in the gentrified neighborhoods. I remember some major news articles coming out when Little Island was built, when we have so many disenfranchised neighborhoods that don't benefit from green space, and yet this investment was gone into a heavily gentrified area that already had plenty of green space to boast. So great, thank you all. I appreciate your participation. I know it's a little bit awkward on Zoom, and I just want to dive a little bit into this topic of heat. And sort of what some of the effects are in general health, and then specifically on mental health. Okay, I think all of us know and are becoming increasingly worried and knowledgeable about the fact that extreme heat kills. But what was shocking to me in putting this talk together is that it kills on average more people than hurricanes, floods, tornadoes, earthquakes, and lightning combined. Overall, in New York City, heat conditions contribute to about 350 deaths each summer. And this is far more than extreme cold, which contributes to an average of 15 deaths. What we also see is a major disparity in that African Americans in the city are twice as likely to die from heat exposure as white New Yorkers. Now, much of this is directly developed and linked to the development of city-based heat islands. And what we define as a heat island is a built environment that can be 2 to 4 degrees hotter than the surrounding green spaces. And there's many things that contribute to this. There's natural components like the intensity of the sun, and with the continued emission of greenhouse gases and the destruction of our ozone, this is getting worse, as we know. We think about human activities. This was touched on in one of the chat comments, like vehicle emissions, use of air conditioning and other industrial energy resources. We look at infrastructure, and this is really a huge thing. Our roads and buildings are made out of asphalt, stone, and brick. When we have a lot of narrow streets and tall buildings like we do in New York City, that reduces airflow. These older buildings, my daughter's in a public school, it's made of brick, it has no air conditioning. They turn into brick ovens in the summertime. And what we also see from these sort of asphalt streets, cement, concrete areas, is that stormwater is diverted away from the city. Now, in the rural and residential areas, we actually see that that stormwater helps with heat by helping through evaporation. But by diverting it away from city streets, that contributes quite a bit to these heat islands that we're seeing. All New Yorkers have a right to safe housing, and they have a right to adequate cooling. But as we can see both from the exercise and from these other points, is that New York City heat is distributed quite unequally, and it follows patterns of other inequities, including race, income, air quality, and access to air conditioning. There's been lots of efforts. The congestion pricing is one of them, as you mentioned, and other mandates, things like a mandate to have air conditioning everywhere. And we know that it's a wonderful idea, but when you get an air conditioner in an old building and it doesn't seal well and it doesn't stick well, then it's not energy efficient. We also know that people who are already low income and see that energy bill rising are less likely to use that air conditioner. Similarly, some of the tree planting initiatives, they're wonderful ideas. We should do them, we should pursue them, but those young trees take time to come to maturity and to be able to actively contribute to sort of the cooling and the green space that we're hoping for. If any of you read this article from a few years ago, this was conducted in conjunction a study by Heat Watch. They actually have these sort of temperature gauge cars that drive the streets in New York City, and they can measure temperature in real time and develop these high resolution descriptions of ambient heat at the human level. And what they found on one hot summer day is that an East Harlem street was 31 degrees hotter than Central Park West. That is a dramatic difference. And to think that there's no implications on health is really hard to believe. This is also a wonderful article just from a few months ago, or well, now actually almost a year ago, in the New England Journal. And they identified, in addition to many sort of organic medical conditions, mental health as being having extreme heat with detriments to mental health. And particularly those who are disproportionately at risk are the elderly and children who have risks to poor thermoregulation, those who are chronically ill and who have dementia, those with limited mobility. It's hard for them to get outside. They're kind of stuck in home a lot. Outdoor workers, those who are from historically marginalized groups and low socioeconomic class, patients on certain medications. I think for your patient population, we worry about those that limit sweating. So thinking about some of the atypical antipsychotics that put them at higher risk for heat-related illness and exposure to poor air quality. One of the greatest, I love this statement in the article where they said that we as a human race are approaching our physiologic and societal limits of adaptation. And knowledge about this is wonderful, but what change we're able to enact is really important. And then diving in a little bit deeper into climate change and mental health. I won't go through this whole slide. We're going to do a little deeper dive on the future slides. But we see that the impacts on mental health are broad-reaching, and it's the result of both discrete acute events, chronic gradual changes, and these effects happen in both direct and indirect ways. When we're thinking about discrete events, such as extreme weather events, things like wildfires and flooding, there's a major wildfire raging right now in New Jersey. We don't even have to look to California these days for this. We see that there are strong associations between these events and increasing levels or flares of depression, PTSD, substance use, domestic violence, suicidality, and successful suicide, need for evacuation from your home, of course, which can also contribute to all of these conditions, and land loss, particularly thinking about our farming community. A conservative estimate of the prevalence of the increase in diagnoses of some of these mental health disorders is about 20%. Worries that about 20% of people would experience a mental health problem in relation to a discrete extreme weather event. When we think about this more slowly, sorry for the typo, and think about sort of gradual changes in heat-related indices such as global warming, the causal relationship between heat and increased aggression has been very well described, leading to increases in violent episodes, including both homicide and suicide. And we know in New York City and wider than New York City that there's an increase in mental health hospitalizations when the temperature is higher. Looking at some of the indirect impacts of heat and extreme heat events, both discrete and gradual. We see increasing challenges for food security. Persons are sort of required to migrate and change their locations involuntarily as places become uninhabitable. And in the climate culture, climate change is really considered what we call a threat multiplier. It leads to sort of increased conflicts, both locally, regionally, nationally, and internationally. When it's hotter, everything else is worse. The vulnerable populations that we've discussed, particularly those with lower sociopolitical power groups, sociopolitical classes, sorry, are at much higher risk. And of course, we saw this in the COVID pandemic as well, but anytime there is a threat to systems and a threat to security of home, food, or other livelihood, you see interruptions in treatment. Medications, people may not get to their appointments because it's too hot outside. They're not going to be able to see their providers. And then the medications that they take, as I mentioned, may increase their vulnerability to heat. And then finally, this topic is a little bit newer, I would say, and a little bit less well studied, but there are what we call perceptual impacts as well. And while it hasn't been well borne out in the research, I think I can personally attest to this. There's many a night that my husband and I are lying awake with what we call climate anxiety. And the definition of this is that it can be prompted by grief about the loss of places, activities, and traditions because of climate change, fear about the potential scope of the impact, and uncertainty about the specific effects, timing, and precise location. I think in less formal research, this is a lot more anecdotal and just sort of survey reports. This climate anxiety has proliferated. And I see this among my own community of friends and family where parents are worrying about their children's futures, that there's a hesitancy among the younger generations to procreate, and this extends well beyond the US. And again, while there's little direct evidence for mental health problems associated with climate anxiety, I do wonder if your patients may be starting to talk about this more in their appointments, and this existential sort of threats and worries might be driving some of their deteriorations. So what can be done, just specific to sort of the heat-related problems? This is not specific to mental health, but of course, sort of practical things at an individual level. Air conditioning is important, even if it is expensive and may not work perfectly, but finding ways systematically to improve that for our citizens is incredibly important. Support networks, encouraging hydration, ensuring people are wearing clothes that are suited for the weather, and limiting strenuous activities outdoors. At a population level, protections and mitigations also are available, but perhaps not efficiently enacted. So heat wave action plans and alert systems, expanding our cooling centers, particularly for the elderly, and ensuring that there's mobility and transport to them, check-in systems for our vulnerable patients, built environments. We're going to talk about that in the next section to address these urban heat island effects. And then, of course, reducing emission of greenhouse gases and clean energy. I think this has been an ongoing threat and worry. And I would just have, without being too political, I'd say under the current administration, this is going to get much worse before we can even consider it getting better. So I think maybe the onus on us is to think about how as individuals we can help to impact this for our patients and for ourselves. Some more direct things. I think there is some literature, and I've included one on the right, although it's not fully validated. And I think you in this audience might know much better about history taking in the psychiatry world that involves scales that are geared exactly towards climate change and heat-related complications. Checking in with our patients about their social networks or living situation, what they're going to do, what's their plan when things get really hot this summer. Giving them education about post-disaster physical reliefs when they happen, where can they get help, where can they get cool, where can they get to cooling centers. And I think as individuals, continuing to actively dispel misinformation, starting to participate if you're not already, and I imagine many of you are already participating in activism and advocacy efforts at the local, national levels, but now's a wonderful time to start if you're not. And then, of course, research. I think much of what we talk about is more cross-sectional research, much less in the realm of randomized control trials. And so I think kind of engaging in this research sooner rather than later and at an expedited pace, I think is really important. Of course, we're also now in a stage where funding for this type of research is threatened, and I think being creative about how we sort of apply for grants and how we devise and name these research studies, as exhausting as that may be, is something that an added sort of challenge that we now have to think about. So we were going to do another exercise, but I think in the interest of time, I think we are going to skip that. And what I'll do is just kind of jump into just a little bit more education about what we call safe and healthy housing, or the built environment, and how that impacts mental health. So we'll skip through this actual mapping exercise, but feel free to do this on your own. The question would be to sort of explore the risk factors between built environments and how that impacts mental health in previously redlined and non-previously redlined neighborhoods. So again, similar to sort of the other heat island topic, we think about both direct and indirect effects of our built environment. And I think, unfortunately, whether we like it or not, human beings spend over 90% of their time indoors, particularly in cities, and this can have many direct effects on their mental health. There's been clear associations and correlations between housing quality and mental health, noise levels, indoor air quality, crowding, and this is, of course, compounded by our immediate external neighborhoods that may also be in decay as well. I won't go through this entire table, but I'm happy to share the reference if you want to read more about this. The ones I've highlighted with the pink arrows are the ones that are a little bit better studies and backing behind them. So we're looking at things like high-rise housing and housing quality, where there's a lot of structural defects, hazards, poor maintenance, etc., leading to elevated psychological distress. And this is particularly borne out in low-income moms who experience a lot of social isolation in these types of buildings. When we're looking at neighborhood quality, which is an aggregate bundle of social and physical attributes, and privacy, we're looking again as increased psychological distress and poor cognitive development in children. The privacy issue is a big one. We'll talk about crowding in a second, but I'm an introvert and I need to kind of reset and be away from my noisy environment when I want to be calmer and relaxed and like try to come back to sort of my center. And without any privacy, this can be very challenging. Residential density, so crowding, again, more negative affect associated with this, greater psychological distress. And while there's no particular psychiatric disorder that's related to crowding itself, when we break down sort of the factors so that there's density in the general area versus density in a specific apartment, that specific apartment density is really important and can have impacts on mental health. And then indoor air quality we'll talk about in a second. Even though some of this data is a little bit softer, I think it's really hard to argue with the data right from our New York City databases. And you can see here in the rightmost column, our patients and persons who are living in public housing or Section 8 housing have dramatically worse housing quality. They have much more maintenance problems than people in owner-occupied, other private rentals in cities and housing citywide, and they have significantly more pets and mold. This map might look familiar to you. This is very consistent with our previously redlined neighborhoods. And as you can see, those same neighborhoods are the ones with the highest amounts of leaks. And that will lead to all of these other types of problems with mold and other housing quality issues. I won't spend much time on this kind of saying the same thing. If you live in Tottenville and Great Kills out in Staten Island, things are pretty rosy. But if you look in Central Harlem, where I live, not so good. Significant numbers with maintenance defects and with cockroaches. And then finally, if we're looking at this by race, again, not surprisingly, but quite disheartening, is that our neighbors who identify as Black, Latinx, and particularly those who are in public or Section 8 housing, have the most maintenance problems more than anybody else. Again, I won't spend too much time on this slide, but this is drawn from the New York City Housing Association occupancy standards. And, I really did not know this, and I think about my patients who have this many rooms is 0, anywhere more than 3, 4 is 0. And I know that many of them are overcrowded. So I don't think I know of any patients or very few who have 2 rooms and often have less than 2 people, or 3 rooms and have less than 2, 3, or 4 people. And so these levels of overcrowding, extremely overcrowded sort of apartments definitely lead to mental health challenges. And there's a variety of ways that leads to psychological distress. When we have this higher residential density, it really impairs a few things. One, there's no time for yourself, no time for restoration, no time for recovery. 2, I think that there is a difficulty when you're always in people's space is to develop really healthy relationships and socially supportive relationships with the people in your home. And when you don't have those social supports, particularly the people that are in your space all the time, this can increase psychological distress and lead to a reduction in what we call both personal and territorial control. These are some of the other indirect effects of our built environments on mental health. We touched on some of these. There's been some excellent studies that link loss of personal and territorial control with learned helplessness. We feel better and have better mental health when we can control our surroundings. And when the opportunities to control our environment go away, then the sense of helplessness can occur. And I think we can all say this, when it's too noisy, too crowded, too difficult to breathe, we give up a little easier. We develop less of a sense of self-efficacy, less of a sense of mastery, and that can really feed into this sort of helplessness model. I think, the last thing I'll talk about a little bit, sorry if a cat comes into the frame. We are new cat owners and haven't figured out the work from home situation yet. We often say, well, just go outside, everything will be better if you leave your apartment. But, I just kind of looked at my own neighborhood and north of my neighborhood. And in northern Manhattan, this is where all of the North River dumping ground is, with lots of noxious facilities there. Up there, they're surrounded by 3 major highways, 2 sewage treatment facilities, a marine garbage transfer center, Amtrak, 6 diesel bus depots, major truck transport routes, and then, of course, Port Authority. And often, again, if you look at some of the maps through that tool, you'll see they're near schools and hospitals and other public facilities. And again, I focused on Central Harlem because this is close to where I live, or where I live. And we see that, our air quality is just not as good. So, we know the indoors isn't great, but the outdoors is not that great either, and it's getting worse. So what can we do? I think one of the things I want to ensure is that I'm not telling you and not leaving you with the sense that it's all doom and gloom, because one of the other things I notice when I walk around is vibrancy. And I love looking at things that they also track on the New York City sort of data explorer. Are people willing to help other people wanting to be in community with others? And in Central Harlem, this is really high. You may look at this for other previously redlined areas, but again, I focused on it because it's my neighborhood. It's a wonderful place to be, but I think many of us won't know that if we don't spend time in those spaces. So I strongly, strongly encourage you, if you're in a bubble, leave it. go walk around these areas, get to know some people in these areas. We did a wonderful initiative a few years ago, post-pandemic, where every Monday we joined a grassroots organization called Harlem Run, and we brought physicians from our division, and we just walked with the community and talked with them. Nothing to do with health, nothing to do with anything, but just getting to know each other as people. And it's incredibly beautiful and enlightening experience. I think in addition, if anybody was inspired by this tool or enjoyed using it, you can use this with your patients. You can use this to help them understand why it's important to comply with their medications, or why it's important for them to take precautions to avoid extreme heat this summer. And then again, I'll just say advocate, 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 educate, educate, educate. And for those with the skills and talents to get involved with real meaningful research here, I'm not that person, but I really hope that you will. On a more local level, partnering with our community-based organizations to ensure that we're hearing them, understanding their challenges, and trying to address that through community initiatives and community-based education, I think is something that we can all do. And the last thing I'll leave you with is that, again, if you like the tool, you can use it for any of these areas, any of these components of the social determinants of health. It's not limited to built environments and heat. You just encourage you to play around with it and share it with others. Earth Day was yesterday. This is my last slide. So I'll leave you with these two statements. We must decide to consume as little of Mother Earth's resources and to produce as little waste as possible, make conscious decisions to challenge and reprioritize our lifestyles to ensure the health of the natural world for present and future generations. We act as a wonderful Harlem-based organization. If you're interested in environmental justice advocacy, they're awesome. And then Courtney Cogburn, a social worker who is heavily involved in this work, very clearly says racism was designed so it can be undesigned. And I think the onus is on us, those of us who identify with many different privileges, to continue to do this work. So with that, I'm going to stop sharing my slides. I really appreciate your engagement. I went over a little bit, but we do have about 7 minutes for questions. And I see that there's stuff in the chat, so I'll open that up as well.
Okay. Thank you so much, Dr. We're going to read through the different questions. So one in the Q&A, is there literature on the physical environments of shelters? Many of our families, especially new migrants, are spending great lengths of time in New York City shelter systems. I know anecdotally a lot of complaints of pest moles and leaks in shelters, and how can we talk about this with our patients sensitively?
Thank you for the question. I won't pretend to have very specific knowledge, but I know that it parallels much of what we're showing in sort of the public housing and Section 8 areas, if not worse. So I can definitely look into some of those resources and share forward what I find. I think the sensitive discussions, I think a lot of it is around optimizing social support strategies. I think it's may not be realistic in a short term to just move people. And we don't know necessarily that always will help with mental health disorders. But for me, the first place to start is for them to first understand and be educated that they have power over some of these issues, that there are resources. And when that feeling of fatigue of fighting the system kicks in, that they have people to turn to. It is exhausting. I don't know if any of you have ever called an insurance company for your own health insurance issues. I know we do it on behalf of patients. I have many degrees. It's exhausting and confusing, and I struggle. So we see this in our patients. So they're not alone, and really just continuing to empower them so that they kind of move away from that sense of learned helplessness and then start networking and accessing both expert and social supports in these areas.
Yeah. Another question. What the slides be shared. So just for the audience, this talk is being recorded and will be made available to the audience via the Just Talks YouTube page in a few weeks, or when that is made available. Another question from Dr. Rosenfeld. How do you recommend introducing trainees to neighborhoods surrounding our hospitals, both as positive, vibrant spaces and as places of disadvantage?
Thanks, Dr. Rosenfeld, for that question. So actually, this talk, I first developed it because Tamara Goldberg, who directs the Morningside West Primary Care Track, asked me last year, so this is almost a year ago, to do this as an orientation activity for her trainees. And actually brought them to Harlem. They left the hospital. That was a longer session. It was about 90 minutes. We did different topics. We did heat, and then we did air quality as another one. And then the third one was food insecurity. But instead of just using the tool, we actually did a true quality of life exercise where we walked around the neighborhood, both for positive and disenfranchised evidence. And then we basically created a fake family of 5. The parents had some health issues and had them go first to a bodega and then to a grocery store and try to figure out how they would spend a budget that a family of 5 would likely have. I think it was very eye-opening for them. I remember one of the residents while we were in there, she was like, you know what, while I'm in here, I'm just going to grab a couple of things. And she just, without thinking, she bought like some nice tea and some other things. And if it was such an expression, nothing against her, of like how privileged we are to just be able to pick up things when we want to, whatever the cost. And so I think that's a great opportunity. I'm happy to do something like that for your trainees, Paul. So, feel free to connect with me. We're trying to figure out how to build this into our Plum Critical Care offering as well for orientation, and maybe doing it even sort of more widely across other Plum Crit programs in the cities. But building it into orientation is a really good opportunity.
Thank you. Are there any specific mental illness diagnoses or psychiatric medications that you, in your research, have found to be more vulnerable to the effects of heat and gentrification disparities among New York City populations?
Yeah, I'm definitely not the expert, but what I see and know from my reading and from critical care, I think are many of the antipsychotics, I think reduce our sweating capacity. And so if you can't cool yourself, you're more vulnerable to a temperature that you wouldn't normally be vulnerable at. I do believe some of the other antidepressants, and then if we think about some of the dopamine inhibitors, I think that also can lead to heat vulnerability. There may be one of the psychiatrists on the call or who is more familiar than I am. But again, I think all of these things are should be looked at. We're going to be sort of much more in this space in the coming years.
Yeah. And I guess the last question is, how can we ensure that our presence as, the Mount Sinai system serves the existing community rather than pushing it out, and we don't maybe contribute to gentrification ourselves?
Yeah, thank you for that question. It's so important. I think probably the number one thing that we can do is there is so much academic work that goes on in this institution that is not informed by the communities. I'm guilty of it by myself. Number one, I'll be the first, and it's something that I'm trying to rectify actively. Bring community voices into this work. Why are we trying to identify problems that we want to solve that people don't care about, but that's not really going to meaningfully impact their health and their lives? I think the most beautiful example of this is our MedPeds program that's based at Mount Sinai Hospital. They are a phenomenal program. They have the luxury of being developed, recent years, and so they could do this all from scratch. But everything about that program, from curriculum development to how they run their clinics, to how they run the rotations, is completely community informed. And it continues to be. And so, at the very least, maybe you want to, bring a community member to your division meetings once in a while. We have a community member on our ethics committee, starting there. And then we're starting to develop initiatives and research studies, ensure that there is community engagement before you devise and write everything up.
Mm-hmm. Thank you so much.
Dr. Jeffrell, can I make one request? I don't know if Fausto, if there's a possibility to save the chat, there's some amazing resources. I don't know who Ilona Silva is, but thank you so much. I really appreciate all of the resources you're dropping him. I'm familiar with some, but not all of them. So thank you.
Yeah, we can get a transcript of the chat, but we can find a way to make the resources available, maybe linking them to the YouTube video when it comes out. But anyone who wants can contact Ilona Silva. As myself, I save some of these links. And so sure, thank you so much. Okay, so I want to be mindful of time. It is 12 o'clock. Thank you so much for your wonderful, amazing talk and the intersection of social determinants of health, heat disparities, gentrification impact on our medical health and mental health. This is extremely interesting and engaging conversation. Definitely things that I haven't had to sort of like think about, but noticing how much this affects anxiety, it affects mood, us as commuters, as citizens of this city and our well-being. I know that I'll be paying more attention to this and looking more into it. Thank you for all the amazing resources that were placed in the chat today. I want to speak for everyone that this was extremely engaging and informative, and thank you so much.
Oh, thank you for having me and for letting me experiment with the virtual format in this talk. I appreciate it. I really, really loved being here, and I hope to connect with you all in person soon. Thanks
Thank
again.
you.
Bye-bye.
Bye, everyone.